Peritoneal dialysis has been around since the 1920s and is an alternative option to hemodialysis. The various techniques used to place peritoneal dialysis catheters include laparoscopic, open, and percutaneous. The focus of this video will be the percutaneous technique using the Medtronic Argyle curl catheter. Medtronic offers a wide variety of catheter configurations and also offers individual accessories and kits. Kits like the one shown are recommended for percutaneous catheter placement and offer a convenient and cost-efficient option. Additional educational resources for alternate insertion techniques are available through the Medtronic homepage using the Healthcare Professionals tab. Medical techniques and procedures described do not represent all medically acceptable protocols, nor are they intended as a substitution for the physician's experience and judgment in treating any specific patient. Before inserting a peritoneal dialysis catheter, there are a few things to consider in relation to the placement of the catheter and the patient. Perioperative planning and preparation are key factors which influence catheter patency. Let's begin by looking at patient landmarking. Among patients, there are various factors to take into consideration when planning catheter placement. These factors include body habitus, beltline location varies greatly, surgical scars, hernias, stomas, incontinence. If a transplant candidate, put a catheter on the left side. Patient preferences, right or left-handed, desire for deep baths. Examination should take place when clothed and in both a sitting and lying position. Note, insertion into the abdomen is the same technique regardless of implantation standard or catheter system. The next step is planning for the surgical incision. During this part of the planning process, it is important to make sure that the surgical site correlates to the location of the deep cuff. The measurement ensures the coiled tip is located in the deep pelvis. The incision is in a perimedian location, and that the center of the incision is 3 centimeters lateral of the midline and toward the medial aspect of the rectus sheath in order to avoid epigastric vessels. Another key step in perioperative planning and preparation is mapping the tunnel tract. Here, it is important to ensure the tract is either lateral or downward facing. Additionally, catheter configuration, straight or pre-curved, will determine the distance from the superficial cuff to the exit site and the exact shape of the tunnel tract. Stencils and algorithms can also be used to help plan the tunnel tract, as displayed in the image. As with any surgery, the last step is to ensure that the patient is prepared for the procedure. Patient preparation should include an explanation of the procedure to the patient, bowel prep, a shower with chlorhexidine the day of the procedure, body hair removal, bladder elimination, and prophylactic antibiotic administration. Once catheter planning and patient preparation have been completed, the catheter is ready to be placed. The following procedure was performed by John E. Aruni, MD. Dr. Aruni is an interventional radiology specialist at the Regional Medical Center Dialysis Access Institute located in Orangeburg, South Carolina. Dr. Aruni is an expert in the surgical aspects of percutaneous peritoneal dialysis catheter placement and is a president-elect of the Vascular Access Society of the Americas, VASA.
As an initial step, we want to determine the surgical site, and that will depend on the patient's body habitus, the size of the catheter that you're going to be utilizing, and then once chosen, we'll anesthetize the skin with lidocaine 1% and about a 1.5 to 2 centimeter linear configuration. And we want that incision to be about 2 centimeters lateral, either right or left, from the umbilicus, and about 2 centimeters above the umbilicus. And in our incision, we do not want to get involved with the inferior epigastric artery, which runs along the rectus sheath. And now we're going to use blunt dissection because we want to get down to the fascia. And I prefer to puncture the peritoneum through the open incision because trying to make this incision around a 21 gauge needle is just too cumbersome. Now I use ultrasound, and you can see the anterior abdominal wall, and you can see the peritoneum sliding back and forth. And I use ultrasound to guide the needle down to that point just above the peritoneum. And then we're going to have a 45-degree angle of the needle, ideally. And now with ultrasound guiding the needle down to the peritoneum, you can see it right there above it. And after you've done several of these, you will get a sense of when you puncture the peritoneum, you will feel the pop or sudden release in tension of the needle, and you'll know you're there. Then I place the guide wire, and it should go easily without any resistance at all. Remove the needle, and now I'll use the inner piece of a micropuncture set. That's the 2.3 French inner piece over the guide wire. And I'm going to inject contrast under fluoroscopy to confirm that I'm in the peritoneal cavity. Unless there's abdominal pathology or the small bowel is adheres to the anterior abdominal wall, it's very difficult to actually puncture into the small bowel. And if the wire is gone easily, you'll get this type of a picture when you inject that small inner stylet. And you can see contrast now is going to outline the loops of bowel. If the contrast stays at the tip of the dilator, you know that you are not in the correct position, that you're probably in the muscular wall, and you'll want to restart and repuncture. But here you can see the contrast nicely outlines the small bowel. And there's a good distribution to both the right and the left side of the abdomen. Again, we'll reinsert the guide wire, and then we'll reconstruct the micropuncture set so that the outer, either 4 French or 5 French piece is in the peritoneum. And now again, we'll make the track that the catheter will use to exit. And that will depend whether you're using a catheter with a right angle, a catheter with an acute angle that will be angled down towards the hip, or if you're using a straight catheter that you may want to exit over the sternum. We use those sternal catheters for people that have a lot of paniculus, and we want to keep the catheter away from that area, and it'll exit the sternum, in the area of the sternum. Now I'm going to place a single 2-0 absorbable stitch into the fascia, and that's going to be used to secure the distal cuff. And here on the back table, you can see the catheter being prepared. The scrub nurse will lubricate the catheter by immersing it in saline and also rolling the cuffs to expel any air that may be trapped within the material. Now an 035 guide wire is advanced through the micropuncture set. And again, under fluoroscopic control, we want to make sure that the wire is down into the deep pelvis. And we're going to widen the track because we will want that distal cuff to be in the rectus, beyond the rectus sheath. Now we'll place the peel-away sheath, and depending on how the patient is doing, we may ask the nurse or the anesthesiologist to give another round of sedation because the peritoneum is so sensitive. But in general, we do these with monitored anesthesia care or modified sedation. You can see me moving the wire back and forth. This confirms that the wire hasn't been kinked. If you mush the dilator and you cannot move the wire, you should check under floor to make sure you have not kinked the guide wire. Remove the inner stylet and the guide wire together. And we'll advance the catheter through the peel-away sheath. And note that we've taken that 2-0 absorbable suture through the cuff, and that will help anchor it internally to the fascia. And this should go pretty much without any resistance at all. Again, we're going to check the position. There's no kinks in the catheter. Good distribution of contrast. We'll remove the peel-away sheath. You want to be careful when you remove the peel-away sheath that you don't pull the catheter out. So you just do it slowly, re-advancing the catheter as needed. Now advance the deep cuff into the rectus sheath, and the superficial cuff was outside. Now we'll secure that suture in just a moment with we'll tie it down onto the rectus sheath. And there won't be any sutures at the exit site. Everything is internal, and this is a additional guard against infection. And attaching the trocar to the catheter, now down the tract that has been previously anesthetized with lidocaine. And you can see that distal cuff, which we want 2 to 4 centimeters within the skin from the site of exit, and this to prevent infection. And we'll remove the trocar, smooth out the catheter, and then we're going to place a saline syringe here and inject and make sure there's no resistance to flow that would suggest a kink. Now, at the Dialysis Access Institute, what we do is place 2 liters of saline into the abdomen once the skin has been closed, and then drain the abdomen and make sure we get a similar amount back. Alternatively, we can use 2 milligrams of TPA, which I lock the catheter with, to prevent fibrin from forming in the catheter.
For additional information, please visit us online.